Tibial plateau leveling osteotomy for human ACL deficient knee. Here are the disclosures for the authors of this presentation. We will start with the basic concepts of this surgery. The idea is to create a hemicylindric osteotomy with the convexity being distal and the center of rotation being just above the proximal tibiofibular joint. The idea is to make a rotation of the distal tibia onto the proximal aspect without having any gap or use of any wedge, which will be stable enough to control the slope in very high slope patients. In this case here, and as an example of a 66-degree slope in a young boy. We will create a rotative osteotomy and correct the slope just behind the tibial tubercle that will be left intact during the surgery. We are cutting from anterior to posterior and then measuring the rotation using K-wires. Here, we have wires needing to rotate, for example, by 6.8 millimeters. For the planning, we draw 3 circles at the proximal aspect of the metaphysis and define the angle of correction that we want to correct. Here, the correction is 20 degrees. We then measure on those 3 circles the distance between the 2 parts of the angle, or the 2 lines that find the angle. This distance is the rotation that needs to be performed during the reduction process. So we would put a K-wire or a mark to be able to see that the rotation of the proximal plateau to the distant aspect creates the posteriorization of the mark from 6 to 9 degrees. We usually draw 3 circles because we want to anticipate, based on the size of the plate, which will serve as our drilling guide, what the ideal radius will be, whether it's 2, 3, or 4 centimeters. We draw these varying radii because sometimes the anatomy of the proximal tibia and the location of the tibial tubercle do not allow for the standard 2 centimeter radius of curvature from the first circle. Here, we will present a case of a surgery performed on a young 28-year-old female with an ACL deficient knee with anterior subluxation of the tibia relative to the femur and a slope of 60 degrees after an epiphysiodesis. The first step of the osteotomy is to osteotomize the proximal tibiofibular joint. This allows for rotation of the proximal tibiofibula. There would not be rotation if it is not released. It is released with the chisel rather than cutting the fibula to avoid any impingement of the osteotomized part of the fibula posteriorly during rotation. Just above the fibula, we insert a K-wire that will be our centering K-wire during rotation. Now, we drill with a 3 millimeter hole to be able to place our plate through the locking screw. The plate will be our drilling guide from beginning to end. You can see once the locking screw is positioned, we can rotate the plate along the proximal aspect distally around the curvature of the osteotomy. Here we decided to use the second hole and we drill the proximal tibia from just behind the tibial tuberosity to the posterior aspect of the cortex. The idea is to create a circular osteotomy that will cut completely the proximal tibia just below the tibial tuberosity that will be left in situ. The cut is continued to the posterior cortex at the metaphyseal-diaphyseal junction to enhance bone healing. If we were to use a smaller circle, we would be unable to cut completely the proximal tibia. And if we were to use a bigger circle than the 3 centimeter one chosen here, we would have a diaphyseal cut which could delay bone healing. Here you can see that we drilled completely from anterior to posterior. We always protect the lateral and posterior aspects with Hohmann retractors to protect the neurovascular structures. The osteotomy is completed using a flexible handheld reciprocating saw. This allows for a 1 millimeter space between the 2 aspects of the tibia at the osteotomy site to allow for rotation. We then make a mark on the posterior aspect of the osteotomy site and then place a K-wire at the appropriate amount of planned reduction anterior to this. A 4 millimeter drill bit is inserted from anterior to posterior to allow for rotation of the proximal tibia onto the distal one. We are then ready to secure the osteotomy site once we verify a reduction. This is done first with a plate medially, and then we place the second plate laterally to further stabilize the osteotomy and prevent movement. At this point, we would then perform any ACL or meniscus surgery. Thank you for your attention.